You've seen our research on social media. Now, join us as we dive deeper into the public health topics of our time, featuring new studies and findings generated by our faculty and researchers committed to advancing health equity. From the Department of Population and Public Health Sciences at Keck School of Medicine of USC, this is Preventive Pros, the podcast.
Hello, my name is Dr. Albert Farias. I'm an assistant professor in the Department of Population and Public Health Sciences. I'm also a member of the Norris Comprehensive Cancer Center, a member of the Gare Family Center for Health System Science, as well as co-director of the PhD program in epidemiology. So I consider myself a health services researcher and a cancer epidemiologist, really focused on healthcare equity. So what exactly does that mean? So most of my research is focused on trying to understand and intervene on why there are racial ethnic disparities in cancer mortality, with a particular focus on the healthcare delivery system as a modifiable factor. There currently are multiple cancer treatments that are highly effective. For instance, targeted therapies for women diagnosed with certain tumor receptors for breast cancer, as well as lung cancer treatments as well, and immunotherapies. Perhaps one of the most effective treatments for early stage cancers like lung cancer is surgical resection. However, when we look at the data, we see that not everyone not everyone are receiving evidence-based, what we call evidence-based guideline concordant treatment, meaning what do clinical trials suggest are the most effective treatments? We find that not everyone receives them, and that there are racial ethnic disparities in who's receiving those treatments. So for instance, for patients diagnosed with very early stage lung cancer, guideline concordant treatment is surgical resection of the tumor. And when we look at the data, we see that some people are not receiving any surgical resection of the lung cancer tumor. And we see even fewer Black patients that are diagnosed with cancer, lung cancer, receiving surgical resection. And so what happens is that, when certain subgroups start to be less likely to receive these evidence-based treatments, it leads to differences and disparities. And the evidence suggests that when we control for the type of treatments received, we no longer see disparities in cancer mortality in general. And so this is really, really important as we start to develop new technologies and new therapies to treat cancer, that we try to identify and make sure that the care is equitable across race, ethnicity, across socio-demographic characteristics, so that everyone has a chance at surviving and thriving and doing well once they are diagnosed with cancer. So when patients don't receive these evidence-based cancer treatments, it tends to lead to differences in mortality. And I think that this is a major contribution to disparities in cancer outcomes. I also acknowledge in my research that there are other determinants of health, right? The social determinants of health that contribute to these cancer outcomes. But my research is really focused on trying to identify the factors within the healthcare delivery system that might drive some of those disparities. And so, for instance, things like physician communication, right? The way that patients interact with their physicians is really important. The other resources within the healthcare delivery system, like patient navigation, community health workers, promotoras, care coordination, all of these factors really drive whether or not patients receive that evidence-based cancer treatment. And so my research is really trying to understand these multiple levels that drive receipt of cancer treatment within the healthcare delivery system, so that eventually we could develop interventions to try and make care more equitable. The passion and motivation behind my research interest is really sparked by my own personal experiences growing up as a first generation college student growing up within Los Angeles County. I do consider myself a Latino scholar. And so a lot of my research questions that I'm able to ask, and a lot of that innovation comes from my own experiences. So when I was younger, going through college, my mom was diagnosed with breast cancer. She was uninsured. I remember having to pay the $50 for her to get a chest x-ray to find out only that the cancer had spread to her lungs, and she was diagnosed with metastatic breast cancer. And so navigating the healthcare delivery system, understanding how she interacted with her physicians and sitting with her at all of these appointments through chemotherapy, post-surgery, really informed the questions and my motivation for my research, are really the motivation for my research today. And so one of the areas that I'm really excited about, that we've been able to use data from the SEER CAP data set. That's data from the cancer registry that's linked to surveys of patient experiences about certain aspects of their care. And we find that Black cancer patients and Hispanic cancer patients tend to have poorer experiences with physician communication, with care coordination, and with their ability to get needed care. And these experiences are really, really important. And we're starting to link it to whether or not they're associated with receiving evidence-based care. And they are for minoritized populations. And so if we could improve the way that physicians talk to patients, whether or not they show them respect, whether or not they spend enough time with them, whether or not they explain things in a way that they understand, I believe that those modifiable aspects within the healthcare delivery system could lead to healthcare equity in who's being treated for lung cancer diagnoses. And so to bring that all together, my passion is to really understand those systems and patients and physicians and how they interact at multiple levels, because I've also gone through that and understand the impact that has on patient outcomes. A lot of what we know about who receives guideline concordant treatment and who doesn't, the prior research has really focused on sort of individual level factors that drive that. So maybe it's culture, maybe it's certain beliefs, certain health behaviors that make patients less likely to get certain treatments. But my focus is really on sort of the healthcare delivery system aspect of it and how physicians and patients interact. My students have very similar research interests in trying to understand the sort of causes for disparities in cancer outcomes. And so my goal as a mentor, as a scientist, is to equip them with tools so that they're able to answer questions that are also related to their own experiences and their own ideas of what's causing these issues. And with an eye towards the sort of healthcare delivery system and how different groups are treated. So, for instance, a recently published paper in the journal Cancer looked at the healthcare experiences for Black patients treated with cancer. And we've identified huge differences in sort of good care and bad care, where we are finding that Black patients more commonly than have been documented do experience racial discrimination within the healthcare delivery system. And it's these experiences that shape the trust that they have in the medical profession, that shape the types of treatments that they receive as well. And so we've published multiple papers on this now, where Black cancer patients will say they'll just get up and walk out of an appointment because other patients are being seen before them. And, those experiences with racial discrimination are causing them to forego care. And so these are really, really important to recognize. And, these questions came from a student, right? And so my job as a faculty member, as a mentor, as a member of the community is to equip them with the tools to be able to answer their research questions that matter most to them. And so I've been very fortunate to be in this position and in the department of PPHS with the tools that I have to be able to foster those research questions in my mentees as well. Mentorship has been vitally important to my career from the time that I was in high school to even now as a junior faculty member, and every step along the way. I've had mentors, and sometimes in different people have been different things to me. I think that I've always felt the need to have a mentor to cheer me on and to celebrate my successes and to lift me up when I was sort of feeling lost or confused. I've had mentors that help in my professional development, mentors who help with my scientific inquiry and methods. And these have come from very, very different people along the way. I think every once in a while we get lucky and we find that one mentor that possesses all of these qualities and different aspects. And so because I've benefited so much from that mentorship, I try to be that for my students as a way to give back and honor my mentors for helping me get to this point. And so I've been recognized by USC and received the USC Mentoring Award for faculty mentoring graduate students. And I try to foster their own research interests and give as much of my time as is possible that allows with all the research going on. But I try to be that for my students. I try to encourage them. I try to foster their own research interests. I try to foster their professional development. And, I really try to increase the scientific rigor of their work as well. I think the outlook of cancer care and cancer care equity is promising. I think that there's still a lot of work that needs to be done to understand the complex nature of care and how people from different backgrounds navigate the cancer care treatment setting. There's great evidence that exists already on what could work to decrease and minimize disparities. But with limited resources, we kind of need to study and prioritize what these modifiable factors are. And so I have a large health equity award research scholars grant from the American Cancer Society to study what these factors are for racial, ethnic, specific minorities so that we could develop that intervention, right? So that we can study all of these factors in one comprehensive study so that we could direct resources towards there. So I'm really interested, as very excited to carry out this research and then to eventually develop an intervention that will have an impact at minimizing these disparities that exist in cancer treatment.
Preventive Pros, the podcast, is produced by the Department of Population and Public Health Sciences at Keck School of Medicine of USC. To learn more about any of our episodes, or to subscribe to our monthly Preventive Dose newsletter featuring the latest in public health research and news, visit pphs.usc.edu/podcast. Thank you for listening.